of introducing our speaker. Tamar Mendelson is a professor at the Johns Hopkins Bloomberg School of Public Health. She's a Bloomberg Professor of American Health, Director of the Center for Adolescent Health, and co-leader of the Adolescent Health area of the Bloomberg American Health Initiative. She served as a member of the National Academy of Sciences Consensus Committee on Promoting Healthy Mental, Emotional, and Behavioral Functioning in Children and Youth. A clinical psychologist by training, Dr. Mendelson studies the prevention of mental health issues and promotion of positive development in urban populations, including adolescents and emerging adults. For over 12 years, she has tested mindfulness-based prevention programs to enhance student mental health and school success in Baltimore City schools. Through the Center and the Bloomberg Initiative, she collaborates with multiple partners to help reduce the number of young people who become disconnected from school, the workforce, and other key supports. And today she so generously is giving up her time to give us this talk, very relevant talk on mindfulness interventions to prevent mental health. Ooh, I can't see that because behind problems and promote resilience. Thanks so much.
Thank you for the kind intro. I'm really excited to be here today and to at least virtually meet some of you. Can you all hear me okay? Sounds good. All right, great. So what I want to do today is to give you a snapshot of two different projects that I am working on. One is around developing and testing a mindfulness intervention for mothers who have an infant in neonatal intensive care. And the other project is around adapting and testing a trauma-based intervention, which is for upper middle school students. And this intervention includes mindfulness as a core component. So just a heads up that both of these projects are still in progress. So I don't have sort of all of the final outcome data or anything like that. But what I'm really hoping to do today is to give you a sense of how mindfulness strategies can be tailored for use with different populations, how they can be delivered in different settings, and also using different modalities. So I also thought it would be helpful just to give you some sense of like some of the formative work and the process that our teams used in developing or adapting these types of programs. So let's see, I'm trying to shift. Oh, here we go. There we go. So many of you may already be familiar with the concept of mindfulness. Jon Kabat-Zinn was one of the folks who's really most responsible for bringing some of these sort of concepts drawn from Eastern contemplative philosophy into Western medicine. And he has some nice ways of defining mindfulness. So many of you have probably heard this first definition of mindfulness means paying attention in a particular way, on purpose, in the present moment, and non-judgmentally. So really at base, mindfulness is about attention. But attention with a particular sort of quality to it. And I like this other quote as well. If you're not hearing mindfulness in some, let me just see if I can move, here we go, in some deep way as heartfulness, you're not really understanding it. Compassion and kindness toward oneself are intrinsically woven into it. You could think of mindfulness as wise and affectionate attention. And I think this ties to you know, what many practitioners and researchers think about in terms of potential benefits of mindfulness as enhancing self-compassion and interpersonal relationships and empathy and compassion for others as well. So there is a good and a growing evidence base for the benefits of mindfulness practices for adults. And there are now a number of systematic reviews and meta-analyses that highlight that mindfulness interventions have been shown to reduce depression, anxiety, and stress, and that they've been found to show sort of these benefits in both clinical and community populations. And so that's a growing evidence base. We know less about the impact of mindfulness on children and adolescents, and also on sort of subpopulations of adults. And so I'll be talking some about those applications. And I'm going to start with the work on mindfulness for mothers who have an infant in the NICU. Okay, so Many babies go to the NICU each year. So about 10 to 12% of the 4 million babies born in this country every year are admitted to NICUs, which translates to about 400 to 480,000 infants each year. So, a lot of families are affected by this, and NICU parents are often really uncertain of what the future will hold. There's, of course, a wide range of reasons why infants are admitted, ranging from, complications associated with prematurity to congenital issues. And so some NICU babies remain for brief stays, some for extended stays, but parents are often sort of terrified and overwhelmed, not knowing what the future is going to hold. And research shows that parents suffer high rates of depression, anxiety, and trauma surrounding these NICU stays. Mothers have been studied in particular, and so it's been found that maternal distress often does not resolve after the baby's discharged from the NICU and can interfere with mother-infant bonding, with potential negative impacts on parenting and also increased risk for infants and children showing behavioral and emotional problems. So this is a problem that affects many parents and may have some downstream negative impacts on parenting and child and infant outcomes. So my team and I did a meta-analysis on interventions delivered to parents in the NICU to try to understand what supports are available currently. What we found was that very few studies have actually assessed parent-focused mental health interventions in the NICU setting. And those that have been studied, there are a number of methodological weaknesses. But also many of these programs do not provide explicit training in stress management or emotion regulation that parents may be able to use in their parenting moving forward. Another thing we saw is that most of these programs tended to use one-on-one intervention approaches or group formats, which can be problematic in NICU settings. So one thing we wanted to explore in addition to this landscape of the existing state of the research was to actually talk with providers and parents in NICU settings and sort of understand their needs and their wishes in terms of intervention. So we did some formative work where we talked with 7 NICU providers that included nurses, physicians, administrators, and social workers, and 6 parents. Just to ask more about the emotional challenges that parents face, what resources are available, what are they using, and what is their interest in an intervention to improve stress management and emotional well-being. And so these are just some of the some selected quotes that exemplified what we heard from providers and parents. So one provider said there's a lot of fear and being overwhelmed. There are worries that their child is not going to be a healthy, happy child, worries that their baby is never going to leave the NICU, worries that this is somehow their fault. And a parent quote that's representative, I just kind of shut out the entire world. I isolated myself and just my life is completely swallowed up whole by what's going on here. I don't want to be social. I'm not in the mood. The thought of enjoying myself outside of here makes me feel very guilty and kind of panicky. I'm not being a good mother. I'm not here enough. I might be missing something important. So what we learned from this, really, small sort of formative piece of work is first that group programs are not a good fit for most NICU parents. So what parents and providers told us consistently is that most parents want to stay with their baby during their visits to the NICU. They don't have a ton of time to visit necessarily. And so when they're there, they want to be with the baby. And then parent visits also don't often overlap with times when staff are available to hold groups. So, so just the logistics of getting a group together can be really challenging. And what we heard as well is that there had been attempts to start various kinds of groups in the NICU, and they all ended up sort of petering out because the attendance wasn't good. We also learned that mothers were much more likely to visit the NICU than fathers. They were more likely to have leave from work, and also that more than 60% of the families in the NICU, this is a NICU at Johns Hopkins, were single parent families. We also learned that both mothers and staff members are interested in flexible, individually accessible intervention strategies that would not require much staff time to deliver. And as you heard from the quotes, there really was a consistent sort of emotional pain around this experience, and sense that parents need something, but whatever has been tried in the setting just hasn't clicked so far. So based on this feedback, we decided to develop and pilot an audio-based intervention using mindfulness practices. And I should pause and say that when I first started this work, I was thinking of using a cognitive behavioral program that I had been involved with. But after hearing narratives from parents about this emotional roller coaster they felt that they were on, it seemed like parents were less that they wanted less problem solving or sort of concrete skills and solutions, and more tools for how to cope with this sort of incredible emotional roller coaster ride. And in many ways, the issues they were up against were not ones that they could fix by coping skills, but more that they needed to accept some of the uncertainties and these sort of large, scary questions. So that led us more to a mindfulness framework. And I should also say I've been doing this work with a wonderful colleague of mine, Dr. Erica Sabinga, who's a pediatrician at Hopkins. And so we collaborated on this. So we partnered with a mindfulness instructor, and she developed, based on some of the narratives that we'd heard from parents, 4 different audio practices. We weren't sure how long would parents want to listen to these, so we developed them both in 5 and 10-minute versions. In addition, we thought it would be important to have some introduction for parents who weren't familiar with mindfulness as to, what are these, how do you use them, what's this about? And so, and also we weren't sure what it would be like for parents to have no in-person contact with an instructor. So we had the instructor did a video about 20 minutes long where you could at least sort of be introduced to her face and she sort of talked through a little bit about mindfulness, the program Rationale, and how people might want to use these practices. So this slide here just gives you a table showing a little bit about these 4 practices in the video introduction. And so these are relatively generic practices, but they are tailored specifically for moms in the NICU from things that we had heard directly from them. And in terms of a basic conceptual model, the instruction included awareness of thoughts, emotions, breath, and body. Some of these brief practices really heightened this awareness. Practicing non-judgment. I think you could hear from the quotes the level of guilt a lot of parents were feeling. So sort of non-judgment, acceptance of the situation, cultivation of self-care, and kindness or compassion. So these were all components in the practices, and that we hypothesized that these would lead to improvements in coping and the capacity to manage emotional stress, improvement in psychological functioning, physiological stress reactivity, and parenting. And we then did a small pre-post mixed methods pilot study just to really explore, do mothers in the NICU, do they want to use this with this program? Do they like it? And are we seeing any indications of potential program benefits for moms? So we used quantitative surveys, and we also did in-depth interviews with moms after they were exposed to the practices. So we recruited 27 women who had infants in the Johns Hopkins Children's Center NICU. These were all English-speaking women, and they had to be able to complete surveys. And the infants needed to be in the NICU at least 2 weeks after recruitment so that the parents would have time to use the practices and do our post-test assessments. And we also wanted to stay away from parents whose infants were in such extreme medical crisis that it would be, too disruptive. So the setting was a level 4 NICU, 45-bed facility with over 800 admissions per year. And this is just a bit of demographics about the families being served. Most families on Medicaid, 55% African-American families, and a little bit over 60% single-parent families. The average length of stay for infants was 21 days. This is a list of the measures that we used in our pre and post surveys. So we wanted to get at symptoms of mental health, mental distress. Also asked about sleep and stress, NICU-related stress in particular, coping, mindfulness, attachment, and compassion. And I mentioned, this very basic pilot where we gave them a survey when they enrolled, and then we gave them the intro video to watch, and we downloaded the audio practices as MP3 files that they could use. We also had a CD player that we, had on hand to lend to parents who may not have technology for using MP3s, but actually they all did, and so that worked fine. We gave them 2 weeks to use these practices, and with check-ins from our staff over the 2 weeks to make sure they weren't having technical difficulties or questions. And then we did a post-intervention survey and in-depth interview with them at the end of those 2 weeks. So in terms of what we were looking at, we wanted to track study enrollment and retention to get a sense of the feasibility of doing this work in a NICU. We also had survey items assessing satisfaction and program use, and that's something we explored in the qualitative interviews as well. And we did very basic paired sample t-tests looking at pre-post changes and outcomes. For qualitative interviews, we recorded and transcribed them, and we had 2 coders review the transcripts independently and generate themes, and then use an iterative process to identify and refine those themes. So in terms of our sample characteristics, the average age was around 31 years old, ranging from 19 to 42. You can see the other demographics here. We had, about 42% African-American moms, 54% white moms, and 4.2% Asian or Pacific Islander. Most moms were married, and there was a split between employed and non-employed moms. So in terms of our feasibility metrics, 75% of the women who were potentially interested in the study ended up enrolling. And then 90% of those who were potentially interested and eligible and were contacted by the study team enrolled. And then 27 women enrolled, 3 withdrew before the post-test due to infants being moved to different facilities, and the retention rate was 89%. So, this indicated to us that some good evidence for feasibility, that that enough women were able to be interested, eligible, and follow through. In terms of acceptability, 33.3% of women reported listening to the recordings 4 or more times a week, and close to 21% reported listening sort of around one to 2 times a week or less. And then 46-ish% reported listening 1 to 2 times or less overall over the 2-week period. Most all women reported having a somewhat or very positive experience with the intervention, and importantly, nobody reported a negative experience. So it's obviously always important for us to look for possible sort of, iatrogenic effects or upsetting, women being upset in response to practices, which we didn't see. And also through the qualitative data, we saw a unanimously positive response. So these are some of the preliminary intervention outcomes that we saw. So we saw significant reductions for women between the baseline and post-program in terms of depressive and anxiety symptoms, and the anxiety arousal scale of our trauma measure. We also saw reductions in negative coping. And I should note that almost all of the other metrics showed trends or, some at least movement in the right direction. We also saw self-reported sleep quality and hours slept improved, and total stress related to the NICU improved. Also stress related to the parent role and to staff behaviors in the NICU and general stress. We saw improvements with all of those areas as well. And these are some quotes that highlight themes that, that we heard in the qualitative data from women. So decreased distress and increased calm was probably the most consistent theme we heard from women. I just noticed I was calmer. I didn't stress as much. After I had the baby, it was like stress, everything boom. Then with this program helping me with the recordings and the exercises, it calmed me down. Another woman said taking those deep breaths and breathing them out with a big sigh kind of helped really calm me down in my anxious moments. Interpersonal relationships also emerged from our qualitative data, and this is not something that we had quantitative measures of, but we saw that participants talked about positive impacts on other relationships in the family. So one participant said, with my son, stress levels are really high, yelling and just being really short with him, and he doesn't deserve that. So after listening to the recordings, I would approach him with a calmer attitude and then have more patience with him. She's referring to an older child, not the infant. And another quote, I reached out to my family, my mom, my aunts, my cousins, sometimes coworkers, you know, they work right there with me all the time. I think if I had kept it inside, I would have burst. So talking about opening up more with others. Enhanced capacity for self-care also was an important theme. So one mom said, I was more in tune to how I felt, my feelings. Before starting this study, I didn't really care about how I felt about anything. After listening to the recordings and saying kind words to myself, I more so felt like I was uplifting myself, like you can do this, you can get through it, giving me a push to say you're in the right direction. Think about yourself, don't forget what's important. Because if I forgot about myself and let myself crumble, then I can't be here for her. Another mom said, I gave myself that time. I allowed myself to just have that 10 minutes or 15 minutes, whatever it was. It was very nice actually to give myself that little time, that little calm down and clear your head. It actually made me pay attention to myself instead of everything else that was around. And then finally, sleep. So we really weren't sure what we would see with this, particularly because moms with infants in the NICU have such disrupted sleep due to, you know, needing to visit the NICU at odd hours or even sleeping there. And so it wasn't clear if we were going to see changes, but actually a lot of moms did speak about this. So one said, the minute I turn it off, the recording, I will fall asleep. So then it will help me sleep better at night. Sometimes before the study, I would wake up in the middle of the night, kind of hyperventilating almost just from dreams that I would have about the NICU. But the breathing helped me a lot with, even if I do wake up in the middle of the night from a bad dream, just lay there and breathe and focus on inhaling deeply to calm myself down because my heart would be pounding so hard, so bad. Another mom said, and the time I listened to it before bed, it was very nice too. I felt relaxed enough to fall asleep and not have any trouble falling asleep. So in terms of key findings, this initial study did provide some preliminary support for program feasibility and acceptability and suggested potential benefits of the program in terms of reducing distress, improving stress management and coping, and improving sleep. And we did see women talk about incorporating skills into their daily lives. This is the first mindfulness program we're aware of for NICU parents. And you know, we were pleased to see that the audio and the video modalities were feasible because this is, these modalities could really enhance the potential for sustaining and scaling up the intervention moving forward. So obviously there are a lot of limitations to this study. We didn't have a control group or a randomized design. This was a small sample size without follow-up assessments, and we used self-report measures. But the study did lead to our receipt of an R34 intervention development grant from NCCIH. So we're right now engaged in this study where what we've done so far is to further develop the intervention program as well as an active control condition to use in a future larger scale randomized controlled trial. So one thing that we learned from moms is that the transition from the NICU home is another stressful point in time where suddenly a lot of new adjustments are necessary. So we developed 4 additional mindfulness practices specifically for that transition home with another brief video introduction. So now there are a total of 8 different practices, each with briefer and longer versions. And in addition, we developed an active control condition that would be similar to the intervention in terms of the modality and the duration and so forth. But the active control is focused on audio files with brief video introductions about infant development. So it's more of an educational audio program. We have also thought about this issue of trying to develop apps to house these programs, but we haven't yet really had the funds to do that piece of it. So we've still been using MP3 files, which does seem to be working. So we did that AIM 1 for the R34, and right now we're in the midst of a pilot randomized controlled trial where moms are being randomized either to the intervention or the active control sort of infant development education program. And we're looking at heart rate variability in a subset of these moms to try to understand a little bit more about stress physiology and how the program may shift some of the physiological stress response for moms. We're also now incorporating not only a baseline and 2-week survey and interview, but also a third sort of follow-up point 1 month after the infant is discharged from the hospital to see a little more about, how is this transition home practices working and how are moms doing a little bit further over time. So we are still collecting these data. We've been slightly disrupted by COVID, but have been able to still continue our virtual work. And so we're eager to see what results we will have from this, hopefully to inform a larger scale randomized trial. Okay, so see how I'm doing on time here. So I'm going to switch gears now and talk. Here's acknowledgements to my amazing team and funders and NICU parents and staff. I'm going to switch gears now to mindfulness in the school context. And I've actually done a number of studies on different kinds of mindfulness interventions in schools, but I'm going to focus on one that's ongoing right now, in part because it's a very different kind of mindfulness than the one I just talked about, to just give you a sense of the variety in this area. So first, why schools? So young people, children, adolescents spend most of their time in schools. So it's a great way to reach them. And in addition, schools offer a really structured context for program delivery. So if programs can be either integrated into existing classes or into times of day where students have a choice of different kinds of resource periods, it can be a really nice way to structure program delivery. And then finally, schools can be a wonderful context for really trying to integrate programming that would shift school climate in a more positive direction, promote a positive atmosphere for learning. So there's a potential, I think, for interventions to really have a broad-based positive impact on the school context. So for those reasons, schools are very attractive settings for doing intervention. I work in Baltimore City, and the context there is that many of our young people live in poverty and are exposed to pretty extreme stress and trauma. One of the principals that we work with said, we did an impromptu survey on how our children experience death, and the number of deaths that they experienced were alarming. I likened it to having post-traumatic stress disorder as soldiers do. However, our children are not post because they are not removed from the situation. So, they're living in communities of concentrated disadvantage where levels of community violence are very high. Many parents are incarcerated or struggling with substance abuse or mental health issues, and young people are really dealing with quite a lot that impairs their ability to sort of come to school ready for learning. growing body of research shows ways in which childhood adversity alters brain development and impacts the stress response system. So we know that this sort of early toxic stress exposure creates disruptions in cognitive and emotion regulation capacities, and that is linked downstream with a range of social emotional problems and mental health issues. So mindfulness may offer some potential to reduce negative effects of chronic stress exposure and promote effective skills for managing stress. And so the hope here is that mindfulness delivered in school contexts may have some downstream abilities to prevent or reduce emotional and behavioral problems. So the intervention I'm going to be talking about is called RAP Club. And this has a long history that I won't go fully into, but I've been working with this intervention for many years. And we adapted it from a clinical treatment program that some of you may be aware of called SPARCS, which stands for Structured Psychotherapy for Adolescents Responding to Chronic Stress. And that treatment was a group treatment for teens exposed to trauma. It was one of the top, or is one of the top 3 interventions disseminated through the National Child Traumatic Stress Network. And in diverse adolescent samples, there's indications that it improved trauma, depression, anxiety symptoms, impulsivity, attention issues, and risk behaviors. So our adaptation focused on changing the intervention from a treatment to a universal prevention program and shifting from a clinic-based population to community population in schools, and moving from just having clinician leaders to a model in which clinicians or trained people with some level of mental health sort of experience co-led groups with peer co-leaders, and the peers are sort of young people from the community who have more trust and buy-in with the students. So this adaptation process occurred over many years, actually, and initially occurred with older adolescents who had dropped out of school, but then we did that work for young people in schools. So RAP stands for relax, be aware, and do a personal rating, which is really clunky to say, but we call it RAP Club. And that's a core skill in the program. So it's a 12-session weekly group. In this study, we hold these groups during the school day. And like I said, they're co-led by a mental health trained person from our study team and a young adult community member. I'll talk a little more about the delivery piece in a moment. And the core components of this intervention include psychoeducation about the effects of stress and trauma, mindfulness skills, which are really core skills for the program, and also cognitive behavioral skills. And this slide just gives you a bit more of a breakdown of these different evidence-based strategies and how they're linked with intervention components, skills, and session numbers. In each session, the time begins with a brief mindfulness practice where students are guided in how to check in with themselves, and that thermometer is used. And then at the end of the session, there's another check-in. So every session has those 2 brief mindfulness practices, but in addition, mindfulness is a core skill that's used to promote awareness about states of mind and used to help determine which other skills to use. Mindfulness also informs distress tolerance skills of what to do when you have a problem, but you can't really solve that problem in the meantime. How do you simply tolerate those feelings without making the situation worse? And for those of you who are familiar with DBT or dialectical behavior therapy, a lot of these components in SPARCS were drawn from the adolescent version of DBT. So these have been widely tested through the DBT intervention, but are applied in this way. This is a basic figure showing the intervention hypothesized theory of change, in which these components addressing emotion regulation, problem solving, communication, psychoeducation, ultimately enhance self-regulatory capacities, which lead to improvements in emotional and academic functioning. So after doing a lot of intervention development and sort of iterative piloting work, we did a pilot randomized trial with 2 Baltimore City public schools. We were working with 7th and 8th grade students. So we had 49 students in the study who were randomized within schools, either to receive the RAP Club program or regular school programming. And we did pre and post assessments, both with student self-report measures and teacher report measures. And the teachers who were reporting on students were not teachers that were really directly involved in the intervention in any way. So we, clearly blinding was not possible, but we tried to engage teachers who knew the students but were not really aware of what the program was about. We did not find any improvements or changes in student self-report measures, but we saw pretty robust changes in teacher reports of how students were doing. So we saw improvements in teacher ratings of student emotion regulation, social competence, authority acceptance really refers to classroom behavior, and then academic competence. So teachers were seeing these improvements in the intervention participants as compared with the controls from baseline to post-test. And we also saw that there was some dose response going on, so that students who attended more intervention sessions showed more teacher-reported gains. We were also interested in sort of, since this is a universal intervention, we hadn't screened students out on the basis of baseline scores, but we did look at that and found that even students with low baseline scores of distress improved significantly in terms of these teacher reports, which suggested to us that the universal approach was appropriate, that we didn't necessarily need to screen out students without baseline distress because they seemed to be gaining benefits as well. So that pilot work led to the receipt of a R01 grant from NICHD and a sort of R01 equivalent grant from the Institute of Education Sciences, which together fund something called Project Power, which stands for Promoting Wellness and Emotion Regulation. This is a large randomized controlled trial in 29 Baltimore City public schools, where we're testing this trauma-informed RAP Club program, this time in comparison with an active control condition, which is called Healthy Topics, and it's a health education program. So the aims were looking at whether the intervention produces improved education, educational, emotional, behavioral outcomes, and underlying self-regulation processes in comparison to the control group. And we're also interested in looking at potential moderators and mediators of intervention effects and evaluating factors related to program sustainability. Because one of our big goals is that we don't just want to develop this program, do the research, and then leave and nothing changes. So we really want to sort of build capacity of schools to continue using these programs. So the model is that we partner with each of our schools for 1 year. And in each year, we try to work with around 8 schools. So we have these different cohorts over 4 years. And in each school, we work with the principal so that they identify a school mental health professional to get training in RAP Club and sort of observe what's going on, and a teacher to get training in healthy topics. We provide our own staff to run these programs, so a group facilitator trained in either RAP Club or Healthy Topics, plus a community member co-facilitator who is also trained in either RAP Club or Healthy Topics. So both the intervention and the control have that same structure. And the hope is really that these school personnel attend a summer training in one program or the other. They then attend program sessions and supervision calls. They're paid for their time. And we want them to feel comfortable at the end of that year that if they want to continue offering those programs and the principal wants to do that, that the school is prepared to continue. They have all the materials and they have the training, and we also offer ongoing consultation if they want it. So this slide gives a just basic of the study design. It says 32 schools because that was our original hope. We ended up with 29 because some of our partnerships just weren't sustainable. But essentially this shows you what we do with each school. So we partner with the school, we collect a baseline assessment on students, and we generally recruited somewhere between 25-ish students per school. After the baseline, students would be randomized to Rap Club or Healthy Topics. After the we delivered it over a 6-week period, twice a week, after which we gave a post-test. As in our pilot work, these assessments were both student self-report and teacher report. Follow-up assessments were conducted in the spring. And I should also say these were with 8th grade students. I can't remember if I said that or not, but these are 8th graders, in part because we felt like this was an important time to help prepare them for the transition to high school. And then the NICHD grant allowed us to follow up these students in the 9th grade to see how that transition to 9th grade went with a final survey. And we also were able to collect academic data from academic records in students 7th, 8th, and 9th grades to see their attendance, their suspensions, their grades and test scores over that period of time. And we did selected focus groups with students about their experiences and selected interviews with school personnel as well to inform our understanding of sustainability. We also gathered cost data to do a cost analysis to inform sustainability. So this is a map of Baltimore that just shows you that we recruited schools in each cohort that really covered a broad range of neighborhoods, but these schools really primarily served low-income communities. Average school size was 458 students. And this slide gives you a sense of our enrollment and survey participation rates for each of the 4 cohorts. You'll see that cohort 4, we are currently finishing up our spring follow-up survey, so I don't have those rates here yet. And this table also doesn't include the 9th grade follow-up rates. So we have good follow-up rates in general across these different surveys. COVID is making this follow-up in the spring more challenging, so those rates are going to be lower. The 9th grade follow-up, we had more attrition because we have to reconnect with students the following year, but we've gotten somewhat better at doing that over the 4 years. Okay, and this slide gives you a snapshot of some of the baseline characteristics of the students in the sample. So, you can see that there's really high rates of distress, particularly anxiety and trauma symptoms are really high. And this again is a community sample. We didn't select them on the basis of any exposures. On the bottom, you can see that we measured adverse childhood experiences, although we did need to leave out questions about abuse and neglect, as these would be reportable. So without those 2 items, you can see that many of these students are endorsing 1 or multiple ACEs. And then, this is just a snapshot of our fidelity monitoring. So for each intervention, for each cohort, we had instructors rate their own fidelity at the end of each session, how much they were able to cover that session, and so on. We also, and that's what these tables show, is the self-rated fidelity. We're also working on having 2 independent coders rate videotapes of the sessions to look at fidelity that way, and we'll be able to correlate that with the instructor self-ratings. Interestingly, the average overall for Healthy Topics and Rap Club was 3.2, showing pretty good levels of fidelity, although you can see that for some of the sessions, it was better or worse. session 9 of Rap Club is notoriously challenging. But overall, we think that those levels are fairly good. And ultimately, we'll be able to look at how Fidelity might predict outcomes as well. So these are a couple quotes from our interviews with school personnel that speak to how schools responded to these programs. One principal said, I love the group sessions that the kids had. We need it because there's just so many things working against them. They're turning to the wrong sources for answers, So I definitely want it because my kids just need that constant reinforcement on what to do and how to handle issues and problems, and it's not to revert to violence. And a school counselor said, yes, I would like to continue offering Rap Club because I feel like when I'm comparing the students that participated in Rap with the students who did not, I feel like they are able to better adapt to the craziness. I feel like they have learned some sort of way to deal with it. So, I'm still in suspense for our final results. The database is locked until we finish all of our assessments, but we are getting there. We've now finished delivering the program at all of our schools, and we're on the follow-up assessments. So hopefully we'll have more news with that soon. But so far what we've learned is that, there are indeed very high levels of youth stress exposure and psychological distress in the sample, even when we're not selecting for that. We see a need for universal trauma-informed interventions from schools' perspectives and what principals and school personnel are telling us. And then we're also seeing, confirmation that Rap Club can be delivered with good fidelity by facilitators, that it has been feasible to offer the programs during school day, and that it's been acceptable to students, teachers, and principals. We're also really seeing the importance of assessing facilitators and barriers to sustainability. And actually, I worked with a wonderful first graduate student and now postdoc, Kim Arnold, who did some really nice in-depth work on barriers and facilitators that we're publishing now. And we are awaiting final data, so stay tuned. And I want to acknowledge the amazing team and funders and city schools. And just in conclusion, overall, I think some of the just broad messages I want to leave you all with are the fact that mindfulness-based interventions do come in different sizes and shapes. They can be tailored to different populations. They can be integrated into different kinds of service settings, and they can be delivered using different modalities. And I think we need to be really sensitive to what population are we working with? What do they need? What is going to work best? And the longer I do this work, the more I also think that understanding the systems of care is critical. So really thinking about the implementation science end of this as well, in terms of how can we promote delivery with fidelity in a sustainable way that is going to really be integrated into the context. And finally, I think that mindfulness interventions may hold promise for reducing mental health symptoms and improving resilience in a number of different populations. And hopefully I've given you some flavor of what that looks like with the NICU moms and the urban youth. So I just want to thank you all for your attention. I would love to have some time for Q&A.
Great, that was so wonderful. Thank you so much for that great talk. Annie, maybe you can guide us if people can unmute themselves, or I don't see anything in the chat room.
Yes, you can hold down your space bar, or you can just go to the participant on your Zoom and you can unmute yourself. But yeah, feel free to speak or share with us via the chat room if you have any questions or comments.
Hi, this is Randy. I have a question, if I can just go ahead. So just coming back to the NICU, Tamar, what are your thoughts about ultimately something like this being translated without having to have research funding? I know you're still looking at that, about incorporating a more robust intervention for those parents, but do you see that as that's where this is headed?
I'm not sure if I understand your question. You're asking about whether What do you mean by a more robust one?
No. You had already said you were working on adding some different features that they told you in qualitative. So I know you're still working on that. My question was about, do you see something like that program that was done really like self-guided, if you will, if something like that would be fairly easy to roll out in the clinical setting without being part of a research project? Like, do you think that the parents would, whether it would be uptake of it, what would have to be in the clinic just to make it happen? Because I think we could learn from what you've, I mean, clearly you've got great research funding, but I think for those of us also working in clinical settings, we could take some of what you've described and try to use it in a clinical way. So I'm just wondering how you would see that working in the NICU.
Yeah, so that has been on our minds since the beginning. You know, how can we develop something that actually would be able to continue without us? And I do think this is feasible. I think that a key piece for us in the NICU settings that we've been working in, and we've been in 2 NICUs, both associated with Hopkins, but different NICUs. And what's been really key is having links with the social workers, because in these settings, social workers do intakes with every parent, every family coming into the NICU. And so if the social workers are on board, they can give families an intervention like this as part of their interactions, and they give families other sorts of information as well. So I think that it's important to have buy-in in the setting, and if the social workers see this as beneficial, it is feasible for them to simply provide the materials. So far, we have not really seen a need from participants to have more in-depth sort of consultation or contact with the research team. So I do think that it's feasible. On the other hand, if you have a setting where either there aren't social workers, maybe there's not like a great gatekeeper to provide the programming, that could be a challenge. Or if the setting isn't really bought in and it's seen as just one more thing that people have to take care of, I could see then that over time it might simply drop off. So I think that that's part of the sustainability would be sort of knowing where it should live in the setting, who should be the key liaison, and so forth. Nurses, we've also thought about being a sort of a liaison point, but in these settings, the nurses were less well positioned to do that than the social workers. And it seemed to fit nicely within the mission of the social workers, but that might be different in other NICU settings. Any other questions?
This is Carrie. I'll ask another question. We had talked a little bit about the tension between really narrowly focusing on one population with your intervention and making a lot of the mindfulness support very specific for that group versus more universal type of tools. And I was just wondering, with your NICU study, again, you talked about how you went back and ended up adding some more sessions to support their transition home. And is that within, you're giving them new skills, or are you giving them a lot of more prompts about specific things like taking care of your baby once you get home?
Yeah, so it was another set of mindfulness practices. So they weren't really focused on tips or practical, sorts of suggestions about the return home. Families do get that from the NICU nurses and doctors, but more just thinking about, partly trying to activate parents to go back to practicing and to sort of use those, and then trying to tailor practices a little bit to that particular situation. To be honest, it's been harder to study the transition home than the time in the NICU, because it's much harder to stay in contact with families once they leave. So that's something we're currently working on in the R34, and we'll see what we find. But we certainly did hear from parents in our qualitative work that that the two most stressful points for them were coming into the NICU and being sort of overwhelmed by the setting, the pace, the uncertainty, and then sort of after acclimating to the NICU, going home, which was also sort of both a relief but also terrifying for many families. Moms would sort of say, I don't know if I can do this on my own. I haven't, and sort of a lot of new questions and insecurities. So really that was what motivated us to think about a slightly different set of practices. Yeah.
Great. Well, thank you so much for taking the time to speak with our group today. I think we all learned a lot, and you might get some follow-up questions in your email, or I appreciate you put your Twitter handle on there as well so we can connect with you in different ways. But just really want to sincerely thank you for taking the time.
Thank you so much for inviting me. It's been such a pleasure. Yeah, so stay well, everybody, and very nice to meet you virtually.
Thank you
You
so
too.
much.
Take care.
Thank you.
Bye.
Bye.